much. Good evening, everybody. I hope to make this session an introduction for those of you who are maybe thinking of pelvic health for the first time. I love it, so I tend to talk a lot, and sometimes I talk too fast. So slow me down if we have to. I've tried not to make it too technical, so I'm going to take you back to some anatomy, and hopefully you're going to find your pelvic floor tonight. That's my goal. Okay. When you're ready, I can share.
Yes, you may start.
Okay. Awesome. Okay. Let's go. Okay, so why do we need to know about it? Well, like I said, firstly, we all have a pelvic floor. Whether we are men or women, everybody has a pelvic floor, and we only seem to think about it when we have problems. So my mission is that if we really learned about our pelvic floor well before we had problems, we'd look after it a lot better. Think about yourselves. You always taught, you only have one set of teeth. Once you have permanent teeth, you must look after your teeth because you're never going to have those teeth again if you lose it. So you make sure you have your dental visits regularly. You make sure you check your teeth. You make sure you look after that brush, floss, all of that stuff. You also only have one pelvic floor. You also only have one body. So we should apply the same thing to other parts of our body. And for me, that's the pelvic floor, okay? So also just a bit of stats, 1 in 3 women will suffer from incontinence. 70% over the age of 65 will have some sort of incontinence. Pelvic floor dysfunction is 23%, and that's only the reported stuff, and that's from the US. It's really difficult for me to find things, statistics for South Africa. Pelvic organ prolapse, that sentence was interesting for me. Prevalence of 3 to 6% and up to 50% when based on vaginal examination. So we're probably all walking around with some sort of prolapse, but because we don't have symptoms, we don't know that it's there. So interesting, hey? So pelvic floor function, how do we need to start this thing is we need to know what our pelvic floor muscles do. Okay, so firstly, it supports the organs, the bladder, the uterus, the rectum. Okay, so the bladder, the uterus, the rectum, they all sit in the pelvis quite nicely and nice and tightly packed in that kind of a position, and they sit on top of the pelvic floor. So support, they important for continence and control. Okay, so I squeeze my pelvic floor, I close the holes, I don't pee and poo all over the show. But I also need to let go so that I can pee and I can poo and I can deliver a baby and I can allow a tampon in, I can allow a penis in. I need that to let go to be able to allow those things. Sexual function and pleasure, yeah, pelvic floor is important. If I don't have a good working pelvic floor, am I going to have this to really feel an orgasm? Not so sure. It forms part of the core, and we're going to talk about this because for me, this is really important. And it's important in carrying load and shifting weight when moving. If you see where the pelvis is, it transfers the weight from the top to the bottom or one leg to the other. So it's really important in how we move, how we function. So we're going to have a look at that when we look at the anatomy. So how does our pelvic floor look? Okay, I did put males in just because I'm sure there's males on this course and I don't want to discriminate against males, even though we are only talking about females. And really, honestly, the biggest difference in our pelvic floor is us women have one more hole. We have an extra hole. Men only have 2 holes. Women, we have 3 holes, okay? And that's sometimes part of the problem. So if we look at our pelvic floor muscles, you can see they're all the same, except just this part looks a little bit different. So at the top, we have our urogenital triangle, okay, which is mainly composed of our superficial pelvic floor muscles. We've got superficial transverse perineum, and that supports the perineal body, which is really, really important because that also supports the lower end of the vagina. Then we've got bulbospongiosis, or sometimes it's called bulbocavenosis, I think especially in male pictures, and ischiocavernosus, and these two are important for moving blood to the clitoris or penis and away from the clitoris and penis. So the superficial muscles are really small. They're made up of really fast twitch fibers, and they're your last line of defense. So as I'm at the toilet and I just really need to clean before I lose my little bits of drops before I get on the toilet. Okay, then at the bottom, we've got what we call the external anal sphincter, also forms part of our superficial pelvic floor, but it's not in the urogenital triangle. Then at the bottom, we've got the anal triangle, and that's really made up of our levator ani, which is our deep pelvic floor. So I'm sure you're thinking, oh my goodness, I've never heard these names before, because we never paid attention in anatomy to all this stuff. But if you're interested, there's some really good resources on the anatomy. So urogenital triangle is up at the top, anal triangle is at the bottom, and we're really going to talk about the muscles in the anal triangle for today's talk. So that's what we call the deep pelvic floor muscles, or the levator ani. Again, male, we can see 2 holes, females, 3 holes. So the levator ani is made up of 3 different muscles, really. We've got pubococcygeus, and it's really named according to where it originates and where it inserts. So it starts at the pubic bone anteriorly, and it goes to the coccyx posteriorly, but it's divided into pubovaginalis, and that supports the vagina and the urethra, and then the puborectalis, which supports the rectum. And puborectalis is a really important muscle because it is responsible for creating the anorectal angle. And the anorectal angle creates a kink in the rectum, which is really nice and clever because we really don't want to be pooing all over the show during the day. So it keeps it nice and pinched. We don't have to think about it the whole day. But when we do need to poo, we need that puborectalis to go back. I always call it like a shot put, like a cat, like a catty when we used to play with that. The elastic needs to come back so that the rectum can straighten out, making it easier to poo, because pooing over a corner is really not ideal. Then we've got iliococcygeus, which is this muscle over here. And that's really for support and function of the pelvic floor. And then we've got coccygeus muscle, which is at the back, which attaches to the coccyx and to the ischial tuberosities. So both the coccygeus, and pubococcygeus together form the levator ani. And they're made up of 70% slow twitch fibers, and slow twitch is your endurance muscle. So I'm on at a low level the whole time. I'm a postural muscle. I'm there to hold things up. I'm there to keep things in a certain place. So I have to be working all the time. And even though I'm a voluntary muscle, I have to have an element of being automatic, because just we can't be thinking the whole day, come pelvic floor, come levator ani, are you working? Are you making sure I'm not peeing and pooing all over the show? That can't be happening. I need to just know that it's doing its job. So I always like to think of it like your upper trapezius, which is holding your head and neck. And then sometimes those muscles get tired. We get tense, we hold our shoulders, we work in front of a computer the whole time, and we develop knots in them. So because we have postural muscles that are endurance muscles, they're on the whole time at a low level, they're more susceptible to developing knots and tension. 30% of the muscle is fast twitch fibers. So that's my quick one, I always call it my Usain Bolt, my big quads, my sprinter. And that I need for when I cough, that my pelvic floor needs to come in. When I sneeze, my pelvic floor needs to come in. When I jump, my pelvic floor needs to come in. And again, even though I have voluntary control over it, I still need to have an element of it being automatic. So that's the most important part to remember when we're trying to train, and when I go into the training, that we need to train both parts. Okay, so pelvic floor is innervated by S234, and it's easy to remember because S234 keeps your pee and poo off the floor, and that's the pudendal nerve, right? And the fascinating thing about the pudendal nerve is that it has motor and sensory fibers, but it also has autonomic fibers with it. So this nerve is really, really important, not only for pelvic floor muscle function, but also bladder and bowel function. So When we have patients who have pudendal neuralgia or pudendal nerve entrapment, these things can cause some serious dysfunction down below, and it can't just be in the pelvic floor muscle that's the problem, or the bladder that's the problem, or the bowel that's the problem. We have to look at everything in its entirety. Okay, so this is my favorite part, because this part, if I can teach everybody this, then we'll all have good pelvic floor. So in our bodies, and we have our thoracic cavity, and then we've got our abdominal cavity, and then we've got below our pelvic floor. So when we look at the core, we are looking, it's made up of the diaphragm at the top, your transversus abdominis in front, which links to multifidus at the back via your thoracolumbar fascia, and we've got pelvic floor at the bottom. And pelvic floor, together with all these muscles, diaphragm, transversus abdominis, and multifidus, together they're forming a core. Okay, so when one of it isn't working properly, the other one is going to do extra or try and make the system balance. For me, the diaphragm is the person that is the coordinator of this whole orchestra. The diaphragm will dictate what the pelvic floor is going to do and what the transversus abdominis is going to do. We also can't separate transversus and pelvic floor. So if my transversus is working, my pelvic floor is working. If my pelvic floor is working, my transversus is working. And this becomes important in our postpartum women who've had either a Caesar or a normal delivery. It's a way we can use to rehabilitate one and the other. So when we're looking at cavities, we're really looking at pressure. And the core is vital in maintaining pressure. You know, the whole system has to work like a piston. So diaphragm, as I inhale, my diaphragm flattens, my pelvic floor will also flatten, and my transversus, my tummy should expand to allow my intrathoracic pressure to increase so that we can get air in, and then my intra-abdominal pressure will also increase, but I'm allowing it to happen. Okay, so I inhale, my pelvic floor goes down. I exhale, my pelvic floor lifts. I inhale, my pelvic floor, exhale, my pelvic floor lifts. So what I want you to do is, if you're sitting down, find your ischial tuberosities, which is your sit bones. Put your fingers on your ischial tuberosities, and you can be sitting on them, and then move your finger pad, just medial to that. So you're almost hooking in. If this is your ischial tuberosity, you could move your finger in and you're hooking in. So you're almost getting into this medial, this levator ani by hooking in medially. Okay, and just take a breath. Just breathe. Don't do anything different. Just breathe. Can you feel anything? Do you feel something moving? Do you feel anything happening? Where are you breathing? Are you breathing into your tummy, or are you breathing into your chest only? If you're only breathing into your chest, try and inhale and expand your tummy. Exhale, let your tummy flatten. On the next inhale, as you expand your tummy, do you feel something happening on your fingers? It will be a slight bulge. Exhale, let it go. Inhale, breathe again. Can you feel your pelvic floor pushing down into your fingers? Exhale, let it go. So if you did find that and you felt that your pelvic floor came down into your fingers as you inhaled, that's great. And as you exhaled, it went away, then you've got probably a good working pelvic floor. If you felt nothing, it could be that you don't know how to coordinate it, or it could be that your pelvic floor is really tight, and so you're not really getting the movement that you should be getting. So then we need to practice. Okay, so simply put, as I inhale, my pelvic floor should also let go or lengthen with my tummy, and as I exhale, my pelvic floor will lift. So I can't tell you how many patients, kids, women, most adults don't get this right, because we live in such an on world. We're so stressed out. We always like fight and flight. So we're breathing up here instead of really breathing into our tummy. So we've now messed up the whole balance, and we don't have a restore to factory settings button. So the body learns this new method of breathing, or this new system. And so the diaphragm is doing this, But the pelvic floor is like, I don't know what you want me to do, so I'm just going to stay stuck here. So often just fixing breathing can make such a huge difference. So why can't we just Kegel? And so as a physio who's been working in this field for so long, I think that's one of the things I hate the most when patients come in and say, but my doctor said I must just Kegel. My exercise therapist said I must just Kegel. I've read on the internet I must just Kegel, but I've been Kegeling and I just don't get better. Well, most of the ladies that I do see when I do examine, they have no idea how to do a proper Kegel. And often they're really just squeezing the anterior pelvic floor, superficial pelvic floor in the urogenital triangle. So they're not getting the deep pelvic floor to do the right thing. And the superficial pelvic floor is really just not enough. So if we have a strong, healthy pelvic floor, we've got good let go or length, and we've got good contract. Okay, so I'm going to use my bicep as an example. If I've got a good bicep, good pelvic floor, I'm going to get good movement into extension, and I'm going to get good movement into flexion. I've got full range of motion, and I've got eccentric control, I've got concentric control. Okay, if I have weak pelvic floor muscles, then I'm stuck here and I'm trying to flex, but I'm really just not getting the full movement. So if I have to put my 3 holds there, I'm really not developing or generating enough force to close off my 3 holds. Okay, so if I have a weak pelvic floor, I'm going to have some issues because I'm really not getting the full movement. Okay, likewise, if I have a tense pelvic floor or hypertonic pelvic floor, I'm here. So now I don't have enough length and I'm really not able to lengthen to get the full range of movement. So I'm also not generating enough force to close off the 3 holes. So I can give the lady with the weak pelvic floor Kegel, she's going to do well. But if I give the lady with a tense pelvic floor Kegel, she's going to get worse because she's just going to go more and more and more and more and more. And she's not going to get the range because she's not letting go. So she's still going to leak, for example. So she's still going to have symptoms. So our too loose, our weak, our underactive is going to present with prolapse, incontinence, back pain, decreased sensation and awareness. They lack full movement. Our too tight or overactive is going to come with pelvic or abdominal pain, spasm, incontinence, pain with sex, difficult with pee and poo, so initiating, having a steady stream, constipation, straining, piles, hemorrhoids, and they also lack full movement. A lot of the ladies I see are a combination because a tight muscle is not a strong muscle. A very long muscle is not a strong muscle. We need both length and strength to have an effective muscle. And that's for every muscle in our body. So it's the same for the pelvic floor. So Kegel is great, but not for everyone. What is pelvic floor dysfunction? Like I said, because we have the bladder, the bowel, and the rectum all sitting on top of the pelvic floor goes across all 3. I don't have enough hands and fingers, but the pelvic floor is going across all 3. Anything that is going on in the pelvic floor or in any of the other organs or in the whole space can affect all 3 areas. So in the bladder, we're going to see incontinence, we're going to see prolapse, we're going to see urgency, frequency, pain. In the bowel, we're going to most commonly see constipation, fecal incontinence, flatulence, prolapse, and pain. And then sexual dysfunction, commonly we're going to see vaginismus, dyspareunia, vulvodynia, and chronic pelvic pain. So all of these fall under pelvic floor dysfunction. So often somebody will come and say, they're coming to me for incontinence, for example, and then I'll give them a questionnaire which will ask them bowel questions and sexual dysfunction questions. And then they often will say, oh, I realize now that it's quite a complex thing and that I've had all these symptoms and I didn't realize that they all fit together. So it's important to understand that. So the role of physiotherapy in pelvic floor health, and it's a lot, right? Education and prevention is number 1. Lifestyle modification. behavior modification, pelvic floor training and rehab, management of chronic pain, and that often will involve a multidisciplinary team as well as looking at it from a biopsychosocial perspective, bladder bowel retraining for optimal function, and then surgery is a thing. So surgery, like with any other, if I'm going for a total knee replacement, I'm going to have prehab and I'm going to have rehab. Same with any surgery that is involved, that is in the pelvis, we should have prehab, we should have rehab. So it's not just about the pelvic floor muscle, because if it was, then I might as well just look at the muscle. I might as well just look at the bicep and not the whole person. But because the pelvis is so important in the way we move and the way we breathe and the way we manage pressure, we can't just look at it in isolation because it doesn't work alone. It works with the back muscle, it works with the tummy muscle, it works with the hip muscle, it works with the glutes. So it's really important that we take a holistic approach to assessing and treating our patients. So I will always start with posture. Somebody who has, kyphotic posture is increasing pressure through the intra-abdominal cavity, which means they're increasing pressure on their pelvic floor. Are they more likely to have a prolapse? Maybe. So I need to know what the posture is doing. Breathing, like I explained before, breathing is key. Abdominal, I want to know what the abdominals are doing and what the external pelvis assessment is like. So the abdominals, do they do what they should do? Is there scars in the abdominal area? Is that scar restricted? Is it going to affect how the pelvis is going to function? Is it causing pain, etc., etc.? Then the pelvic floor muscle assessment. So it's not even the first thing that I do. And often, sometimes on the first visit, I don't get to it because there's so much to explain and understand and expect for the patient to understand before we can even do a pelvic floor muscle assessment. And then, can you bear load? So if I'm going to train your pelvic floor, I can't just train and expect that I'm going to give you a few exercises and then you're going to be okay. Can you use your pelvic floor in load? And load might be that I'm just sitting here and talking to you. That might be load for someone, because as I'm talking to you, I'm creating pressure in my intra-abdominal cavity and I need my pelvic floor to respond. Or it could be that I am a CrossFitter, and as I do my snatch or as I do that, I don't want to be leaking as I do those things. So load is different for different people, but we need to make it specific for every patient and in the perspective of the pelvic floor. So function and exercise goes together with load, and function in everyday life. So my postpartum lady who has to carry the car seat and the baby and is breastfeeding and is leaking, what am I expecting her to do? And how am I going to get that leaking to be less with the functions that she's required to do in the day? So pelvic floor physiotherapy really does encompass a big perspective and looking at the person in whole. So it's really not always so easy to just say, let me have a look at your pelvic floor. Can you contract? Can you relax? Okay, good. Kegel, move on. I must admit, when I first started this part of my life and I didn't know that much about the field, that was what I did, and it did help. And you'll see research that will show that just doing giving education and pelvic floor muscle training is enough to help some people. And yes, it is enough to help some people. That's why even if you can just educate on breathing, correct toilet position, and how to correctly contract the pelvic floor, you're already doing so much to help that person. But for some ladies, it's going to be enough. But for some ladies, it's just the beginning. And there's so much more that we need to look at before we can really say they've got a good working pelvic floor and they've got control over their dysfunction. Similarly, pelvic floor changes through the ages, right? My teen pelvic floor, my kiddie pelvic floor, my teen pelvic floor, my postpartum pelvic floor, my menopause pelvic floor, and my geriatric pelvic floor are not all the same pelvic floor, and they're all going to present with different things at different times. So pelvic health needs to happen through the ages, and you need to understand the outside influences on the pelvic floor. So how did my pregnancy affect my pelvic floor? How did my lack of estrogen affect my pelvic floor? As I'm getting older, how does my posture affect my pelvic floor? Or my lack of movement affect my pelvic floor? Okay, let me take a breath. So pelvic floor assessment in a nutshell, besides looking at all the other stuff, but actually just looking at the muscle, there's two essential ways that we're going to do this. An internal exam, which is the gold standard, okay? And it's the gold standard because you're really getting onto the muscle. Physios are trained to assess muscle, to feel, what does the muscle feel like? Is there good, if I palpate it, does it have good normal tone? Is it hype? Is it tense? Is it pop? Does it have, does it react to forces? So because the pelvic floor is where it is, an internal exam is the gold standard. But we need specific training in this, right? So not everybody wants to, especially if you're a physio, not everybody wants to be doing PVs or PRs. And so not everybody wants to be able to help this population by doing internal exams. However, if it's a passion, then this is what we need to do. And it does require specific training. So this is where scope of practice becomes important, as well as making sure that you have the correct skills to be able to provide the service. So do not do internal exams if you're not trained for internal exams. And I always say to my patients, because that's the thing that they're most scared of, I always send a pre-thing to say, this is what to expect from your first visit. And then when they see the internal exam part, they get freaked out. It is not a must. People have autonomy, and they need to consent to the exam. So if they decide that this is not for them, I can still assess their pelvic floor externally, although I might not get all the nuances that I'm looking for from an external exam. So it's not a must, but it's always good to be able to do when your patient is ready. So there has to be informed consent. Okay, and there are contraindications and precautions. I will never do an internal exam on somebody that's pregnant. I will also never do an internal exam on somebody who's menstruating if they are not feeling comfortable with it. And if there's also an infection, we're not going to do an internal exam. So obviously gloved, usually through the vagina, and then we're able to palpate within the pelvic cavity, but also palpate each of the muscles. So you're able to palpate the fascia and the ligaments, obturator internus, coccygeus, move over, do the other side, and also feel where things are in space. Okay, so what's good about when we palpate is, are there trigger points? Are there areas of tension? Do I have good range of movement? Is left and right equal? Is there good sensation? Can she feel where my finger is? Can she contract this point? Does she have good awareness of how to activate her pelvic floor? In those that I can't do an internal exam, like children, we're definitely not going to do an internal exam. I need to be able to know how to do an external exam. In sexual pain, I'm very careful about an internal exam, because already these ladies are very traumatized about the pain in the area. They've had bad experiences from both medical professionals and sexual partners. So we go very carefully. And then if a patient is a virgin, there's other things that I can do. I really don't want to be the person doing an exam on them. So this is a pic with a kid. I like this position when I use kids, because it helps me to get to the pelvis when it's open, and I can palpate what's happening on the externally through the pelvic floor. I can do it over the clothes. I can also go to the coccyx and feel what's happening with the coccyx, and if the coccyx is going to allow if the pelvic floor is going to allow some coccyx. Oh my goodness, if the pelvic floor is going to allow my coccyx to move or not, which will give me an idea of tension. And then I use ultrasound. I use transabdominal ultrasound in kids, and for ladies, I could do both transabdominal and transperineal. So ultrasound, It's not, I don't use it for any diagnostic purposes, but mainly like a biofeedback resource. And so I don't have good pictures, unfortunately. But transabdominal, we're going to visualize the bladder. And then I can visualize the pelvic floor based on what the bladder is going to do. So if the bladder lifts, if the pelvic floor contracts, my pelvic floor can lift. If my bladder goes down, am I getting good lengthening of the pelvic floor? So this video that I'm going to show you is a little girl that we were practicing breathing. And as she inhaled, you see her pelvic floor descend, or her bladder descend at least. And as she exhales, it goes up. And then I ask her to push to pull, and you see it descend even further. So I'm just going to play this for you. Okay, so there's an inhale. You can see it descend, and then a push to pull, descend further, and then exhale. Inhale, exhale, push to pull. So I often will use it because it gives the patients a visual, and they really like, oh, that's what I need to do. I'm like, okay, so it's a good biofeedback tool for me. The goal of physio is basically you want to optimize bladder balance and sexual function. So that might be through improving the pelvic floor muscle, improving tone and control, improving anticipatory function, because your pelvic floor needs to anticipate. We want endurance, we want awareness, we want control. So when we talk about exercises, again, it's not just a Kegel. I want length, and I want length, and I want strength. I want you to be able to feel that you can get it long. And I want you to be able to feel that you can activate and shorten it. Are you moving your pelvic floor from posterior to anterior? Because that is the direction the pelvic floor needs to move. Or are you just contracting the superficial pelvic floor in the front? Can you connect the two to the middle, and then can you lift it up to your belly button? Because your pelvic floor needs to squeeze and lift. Can you do the slow contraction? So can you give me a 20% and hold for 20 seconds? Can you give me a 50% contraction and hold for 10 seconds? Can you give me a fast twitch? So can you give me a quick squeeze, let go, squeeze, let go, squeeze, let go, squeeze, let go, squeeze, let go. If I ask you to cough, can you squeeze and cough at the same time? If I ask you to do a jump, can you jump and squeeze at the same time? Can you just do all this in lying? Because we start in lying because it's the best place to feel your pelvic floor, because you're not against gravity. But life doesn't happen in lying. So we might start in lying, but can you do the same thing in sitting? Can you then do it in standing? And then can you do it in moving? So I can get you to do brilliant contractions on the bed, but if you can't do the contraction walking from point A to the toilet, then it's not going to help, because you're still going to leak on the way. So the rehab process needs to go through all these positions. And then for me, intra-abdominal pressure is really important. Just blowing my nose is intra-abdominal pressure. So is my pelvic floor kicking in automatically as I raise my intra-abdominal pressure? Is it providing the support as a core should? And then everyday life, anticipation. If my son suddenly throws a ball at me and I don't catch it in time, fine. But I don't want to be not catching it and leaking at the same time because I wasn't ready for something. Or I don't want to go and have a dance with, go out for the night, have a dance, and as somebody spins me around, I end up leaking at the same time. That's everyday life. No, I don't want to have that kind of stuff. So little things that we can help with in terms of teaching: never hover over the toilet, okay? Because when we're hovering, we don't relax the pelvic floor. I need to keep myself active to just hold myself over the toilet, and so I can't really let go and relax to let my pelvic floor go. Don't strain on the toilet. We're going to talk about that now. And don't hold your breath during exertion, because can you see what's happening? All the pressure that's happening in the tummy has to go one way, and pressure needs to be released, and it's going to choose the path of least resistance. And if we have 3 holes at the bottom, it's going to choose one of them, right? Because we're holding the breath at the top, so we're not letting the pressure come out the top, so the pressure is going to come out somewhere. So that's important. We want good, healthy habits for bowel and bladder, because if we have a healthy bowel and bladder, it's easier to manage anything. So water, fruit and veg, blow to go, we're going to talk about that now. Moving, exercise, knowing how to relax and contract the pelvic floor. Good toilet position, which is the second thing I teach every patient. So the first thing was breathing. The second thing is toilet position. So correct toilet position, remember I talked about the anorectal angle, and that is what pinches your rectum closed. And when we go into a squat position, the coccyx and the sacrum move backwards. And so automatically the pelvic floor will lengthen, causing the rectum to straighten out, making the passage of stool so much easier. So if you're sitting and doing this on the toilet, no good. Feet up, squeezing, tummy tight. I'm squeezing my tummy, so then my pelvic floor will squeeze because the two of them are linked. Then I'm definitely not going to get anything out. So to create the squat, we want to keep feet supported, knees slightly above hips, and good breathing. We want to breathe into the belly and then go because then my pressure is being equalized. If I go, I'm pushing down, the pressure is going down, but I'm also closing my pelvic floor, so I'm making it difficult. And that's often our prolapse patients strain. Okay, so they're not constipated, they think they are, but it's just that they've got poor toilet mechanics and they're straining. So eventually the poo doesn't come out, but something else does. So changing that is really important. So I always say blow to go. If your mouth is open, your pelvic floor is open. If your mouth is closed, your pelvic floor is closed. So go and try this at home. I promise you it will be a game changer, especially for the ladies in this talk. So I hope I have a bit of time, but I thought we could just do some case kind of presentations. Miss J, she's 48 years old. She's had 4 children, normal vaginal deliveries, no problems. Had a hysterectomy in 2021 with complications where there was a hematoma. She had a vaginal hysterectomy, but then there was a hematoma which caused a lot of pain. After many investigations, they found out it was a hematoma, had to have it removed and drained and treated via abdominal incision. She came to me complaining of pain with exercise, left hip pain, and stress urinary incontinence with sit-ups and star jumps. And she'd never had incontinence before. She had an abdominal scar, which was mobile on the surface, but stuck in deeper layers, apical breathing. She PFM, her pelvic floor had a good contraction, but she couldn't let go. She had increased tension throughout the pelvis, trigger points in both the left pelvic floor and the obturator internus, which was contributing to her hip pain and was reproduced her hip pain. And then biopsychosocial, she was very upset that she had to have an abdominal scar. She had 4 normal deliveries, never had any scars on her tummy, not a stretch mark on her tummy, was really so proud of that, and then had the scar, and that was a real issue for her because it was associated with the complications and the pain, and she didn't want the scar. So we did a lot of work with accepting the scar, releasing all the emotion that went with the scar, and that helped a lot. So education, correcting her breathing, scar mobilization was a big thing and made a huge difference to the stress incontinence. Awareness of all that she holds in her pelvic floor. So the loss of her uterus, the complications, we really had to emotionally deal with all of those things. We had to do down training and let go of her pelvic floor. We used trigger points and myofascial release as a treatment modality. We retrained her pelvic floor through the full range of movement, and so that she wasn't holding. We learned how to use the quick fibers for jumping and use her pelvic floor with correct core and breathing. A home program, and she was good. So that took about 3 sessions, and she was really so much better after that. In this case, what I do want to highlight is the biopsychosocial approach here, just because I would not have been able to release her pelvic floor or get length in her pelvic floor if she wasn't ready to emotionally also release her pelvic floor. Us women, we hold a lot in our pelvis. The pelvis is the birth of everything and everything womanly within us. So we hold a lot more than we think we do in our pelvic floor. And that's important to understand. Miss S, 55-year-old lady, 2 children, normal deliveries, no problem. She's a housewife. complained of urgency, frequency, and nocturia. Her bladder diary at the time, on initial evaluation, she was going every 30 minutes and it was about 50 moles. She wasn't taking much fluid in. So every time she had an urge, she went to the toilet. So even if it was just for a few drops, at night, she was going about 8 or 9 times a night. So she wasn't sleeping at night either, and her husband wasn't sleeping either because he kept waking up every time she went to the toilet. She had a history of recurrent UTIs, which I question, was it just this habit that she created? She may have had a proper UTI to begin with, which maybe started the snowball of bad bladder behavior. And she also strained for bowel movements. So we did lots of education about the bladder and the bowel and how the pelvic floor muscle and the bladder need to work together with one. If the pelvic floor contracts, the bladder relaxes. If the bladder contracts, pelvic floor relaxes, and the two need to work together. And we used that to retrain her bladder, correct breathing, mind over bladder, that she's in control of her bladder and she needs to be able to do that. The bladder is not in control of her. We retrained pelvic floor for slow holds so that we could inhibit the bladder contraction every time she had an urge. Let go, we trained, and we used a bladder diary at baseline and for time toileting. So she had to, if she had the urge to go at 30 minutes, could she push it to 35? Could she put it to 40, to 45? And so we used that for training. And that we used a bladder drill, which is, if I feel the urge, but I know I don't need to go, can I squeeze to decrease that sensation of urge? So my pelvic floor contracts, my bladder shuts off. Correct posture on the toilet for pee and poo, and a home program. So she's also done quite nicely. And then lastly, Miss E, 29-year-old, one child with a C-section. She's a doctor and on her feet the whole day. She had a rectal prolapse pre-pregnancy. She was a ballet dancer, had a history of dyspareunia and vaginismus, struggles with bowel movements all her life, and now is even more conscious about it post rectal prolapse. She's had rectal prolapse surgery. She gets stressed easily and she's fearing another prolapse. So that's why she even had a C-section, because she thought anything, if she put any pressure on her pelvic floor, she will relapse her prolapse. I don't know if I can say it like that. So again, education, prolapse education was huge, but more so about managing pressure and how do we manage pressure within our body and outside of our body. Correct breathing was very important for her to be able to not be so stressed and to relax and to calm herself down. And if she was breathing better, she had better pelvic floor control, she had better bowel movements. Awareness of all that beholds in a pelvic floor. She had to stop gripping because she learned she was already probably had a tense pelvic floor, which probably led to the straining, which led to the rectal prolapse. But now that she was scared of something coming out, she was gripping even further, creating more tension in her pelvic floor. So she's still a current patient. We're working still on down training and let go. And when she gets stressed and she can't manage herself, she'll come back to me. We did lots of trigger point and myofascial release, and I've taught her how to release using a wand or a dilator. We are retraining her pelvic floor muscle strength through full range of movement. And strength, I'm not really spending so much time on because she really has to let go, especially with intercourse, especially with pain, her chronic pelvic pain. And a lot of that is to do with posture and stress relief. So with her, I also use a much different approach. We do Qigong, we do pelvic bowl meditation, hip and pelvic exercises with focus on opening. All right, so who should you refer? Postnatally, you can refer for just a general check. Bladder issues, bowel issues, sexual issues, prolapse, and pain. So anything related to the pelvis, refer. So I love this slide. If you refer for a sports injury or any injury, you refer for rehab, you send for rehab, you immobilize, you do all those things, then why don't you refer for a C-section or a normal vaginal delivery? These are huge processes that people go through, whether it's a normal delivery or it's a C-section. It comes with so much emotion. It comes with a bit of trauma. And so they need rehab. We all need rehab just as much as the sports injured person does. So my take-home points: take care of your body. It's the only place you have to live. Women's health matters at every age. All forms of dysfunction are embarrassing and definitely underreported. So a lot of your patients are coming to you, but they're not going to say it. They're not going to say that they're struggling with these things until it's way beyond their control. The pelvic floor muscle complex plays an important role in function and dysfunction. And we only ever think about it when we have dysfunction. But if we keep it healthy from the beginning, are we not going to be better about preventing our dysfunction? Physiotherapy offers a conservative approach to optimizing function. And the conversation starts with us as medical professionals. We need to create a safe space for women so that they don't have to suffer in silence. And you don't have to be the expert. You don't have to be the pelvic floor physiotherapist that has all the info, but you need to be able to create the safe space to say, 1 in 3 women are suffering the same as you. You don't have to live with this forever in silence. Education is key, and that's where I spend most of my time, because when we know better, we can do better. So thank you very much. I will open up for questions. And thank you for listening.
Yes, tells me that was a great one. Very empowering. I enjoy teaching, and I wonder how physios feel when I teach, let's say, HIV medicine.
Yes.
I got a sense of how they feel, because you're on the other side as a physio teaching your science, quite intimidating. But I think you managed to really, start it where it needed to start. You build nicely, and I really want to appreciate that.
Thank you.
My dearest ladies and gentlemen, if 1 or 2 physiotherapists would like to make comments, or even a clinician, do raise your hands. It would be great for us to hear from you. Tasvi, you may stop sharing your slides.
Thank
so
you.
that we the
Perfect.
bandwidth. Yeah.
Great.
So there's a number of questions which I saw, and I'm trying to just cluster them. Someone asked about patient education, and they want to understand,
Yes.
what tools do you use, because you said there's a lot of home care stuff.
Right.
Yeah. Yes.
Awesome question. I think that's where every clinician has the most impactful, they can make the most impact in education. So look, I have lots of things. I have a model pelvis, I have a crocheted vulva, I have pictures, I have all sorts of things, but you don't really have to have all these things. This is because it's my tools. I also have laminated pictures. So I have a picture of the pelvis, I have a picture of the bladder. And if you understand the anatomy, just really explaining to somebody how their body should work is so impactful, especially when it comes to bladder and bowel. Correct toilet position, correct breathing, and understanding that pelvic floor and bladder are connected. So if I squeeze my pelvic floor, my bladder is going to relax. If I'm ready to go and I want to wee, my bladder is going to relax, and my bladder is going to squeeze, and my pelvic floor is going to relax. Just educating about that, educating about good bladder and bowel habits, water, good fruit and veg is important. This is every day. We must pee and poo every day, so they can practice it if you just give them the right tools.
Yes.
So education for me is huge. Breathing and toilet position, if you can just do those 2, that's already such a huge start.
Yeah. And maybe to build on that, because this is now my question, which I had to say, it seems like there are basic things that should be taught to every person in the world.
Yes.
So how do we, because I haven't seen any community level intervention. I'm learning this because I'm a health professional. I don't know how the layest person, my sisters and brothers, how they handle it. Have you seen any best practices around that?
Honestly, in our country, this is really it's starting to grow as a field. If you look at the US, the UK, the NHS has pamphlets on everything. So the NHS, you can go to the NHS website, Australian website, you will find everything about prolapse, everything about incontinence, and information pamphlets. We don't quite have that yet, but it is growing. It is getting there. Our ComServe physios are learning a lot more about it at an undergrad level. Exactly what we were talking about. That how can I just educate? So we're getting there, and definitely primary healthcare. We're doing antenatal and postnatal classes in primary healthcare. That's the best place to educate. And I want to take it a step further. Can we not educate our kids? If we educate our teenagers about pelvic floor, they're going to make better decisions. I never knew about a pelvic floor as a teenager. So we're not there yet, but it's we all have the skill of anatomy and we know physiology. So we can educate anybody.
Superb. So there was a case shared by Zohra Mayet at 1825. She says how to assist an 84-year-old woman who's got a prolapsed bladder. She has a ring, still passing frequent urine, the catheter is not helping. She's asking about surgery, but maybe if you can respond from a physio based on the topic, because surgery is beyond the scope. And Zohra, we do have a previous topic where we had an obstetrician talking to the topic, but let's look at how you could
so obviously at that age, if surgery is not an option, you want to do a conservative option. I'm not being ageist, but my 80-year-olds are not the easiest to treat. They've had 80 years of learning, they've learned how to use their body in a certain way. They are not always so happy to have examinations done. And they really also at 80, your muscles, because of the lack of estrogen, your muscles have become pup, for lack of a better word. And now to really be able to generate force to create some strength from the bottom, it's not always easy. Having said that, I've had some great 80-year-olds, but most of my 80-year-olds, if I can just teach them good pooing, because often they're still straining on the toilet, I can't think that I'm going to help them really manage their prolapse. So I always say, I don't want to see you when you're 80. I don't want to see you when you're 70. I don't want to see you when you're 60. I want to see you when you're 30, 40, 50, so that you're learning all the skills to manage your pelvic floor. So when you're 80, something is going to change. You're going to not have so much estrogen. You're going to be weaker. You're not moving around. You might still have the prolapse, but you already have the muscle memory because you've been doing it for 30 years already. So starting at 80, not my best place. And I personally struggle to teach an 80-year-old how to do it the right way. So I use whatever I can to just say, squeeze and let go, hold a fart, don't let that fart come out, please don't let the fart come out. And I'm hoping for the best, but I can't say I have great results.
No, I think that's good. Kanisa asked, she said that, is it normal to have an urge to pee desperately and pee a little, and
No.
she says it doesn't take 3 to 4 seconds to finish.
Definitely not. Definitely not normal. Your normal pee should be at least 15 seconds.
Yeah.
Not okay, so your bladder capacity is 300 to 400 moles. If you are peeing and your normal hours is 3 to 4 hours that you should be able to hold for. So if you're doing anything less than that, you've lost mind over bladder connection. It's now bladder over mind. The minute you feel the urge, you're going. So the bladder's like, hey, this is great. Why must I go to my full capacity when she's going to respond to me at 50 moles? So I will keep giving her an urge at 50 moles. Then I don't have to stretch. So you've now retrained your bladder to give you that first sensation at 50 moles, but you need to retrain it to go to 100 moles and so on. So definitely not normal. Definitely not normal.
Superb. So one more question, then we'll take hands so that you can take a deep breath. Kitimeti says, what causes one to have a uterine prolapse 4 weeks after a normal vaginal delivery? I think she sort of thought it would happen immediately, but why later? Yeah.
Okay. So did she say 4 weeks after vaginal delivery?
Yes, it says within 4 weeks of a normal vaginal delivery.
Okay. Okay, so this is my vulva, but I'm going to turn it this way. I'm going to take out my clitoris and just give you a look. Okay, so remember now you have had 10 months, let's say 40 weeks of pressure. Okay, as your baby was growing, it was going to move things out of the way because it needed the space. In 4 weeks, remember, we don't have a button that says restore to factory settings. We don't. So at 4 weeks, that's all that stuff and all that space is still trying to get back to where it needs to be. At 6 weeks, you're going to go for your checkup, and that's really to just make sure that everything is in order. But 6 weeks is not a golden mark to say, everything is back the way it should be. It isn't. Remember how big your uterus was? Now it needs to come back, and it will drop a little bit. But you need to be aware of, is it dropping more than it should? So most people, when they go for a 6-week check, the gynae will check and say, oh, maybe your uterus is a little bit low, but it's normal for this stage. You need to be aware of what symptoms are you having. And then definitely you can get a prolapse like soon after pregnancy, because you've had all the pressure, and you haven't had something to counter pressure. So it's a common thing, but it is easy to fix because it's so early. If you learn the right ways to manage the pressure through pelvic floor retraining, through correct tummy mechanics and breathing mechanics, so that the pressure is now not going through the hole, but the pressure is maintained nicely within the intra-abdominal cavity, you can definitely change the prolapse early on. If you leave it and you keep doing bad things, which is not maintaining the pressure, remember the pressure is going to go out of the area with least resistance. And if that's your vagina, then that's your vagina, if you're not going to give it some resistance.
Superb. Okay, let's get some audio. Dr. Mushud, are you able to unmute?
Yes.
Yes,
Hello?
Doctor.
Hello.
Yeah. Good afternoon.
Afternoon. Evening.
Good evening. Sorry.
No problem.
Anyway, I would like to, prolapse is a case anyway, but
Yes.
like in this posture, back posture, in line when delivery. You understand? To some people, skills, shout, this, that. At the end of the day, when they deliver, they start complaining of pelvic pain.
Yes.
So how do we educate such people?
Okay, so you wanting about education post-delivery or within pregnancy?
Yeah, no, during ANC.
ANC. Okay. So pelvic pain in ANC is a whole nother hour topic. And it's really, so we know that the symphysis pubis is going to have some separation. And we also know that we're going to get some separation at the back in the SIJ.
Yeah.
What happens is, when there's shearing forces, this model doesn't move, but when there's shearing forces, that's going to cause pain. So ideally, we want to get the pelvic floor to do something to keep this stable, We want to get the tummy muscles to help. Depending on the where we are in the pregnancy, preferably second trimester, usually the patients are going to be able to understand and get a good contraction, and we teach them behavior stuff. So don't get out of the car one leg at a time. Keep your legs together when you're rolling, so that you're avoiding the shear.
All right.
However, when they into their late pregnancy, sometimes no matter what we do, it's not going to make a difference, because there's so much pressure coming down that the muscles just are not going to create enough counter pressure. And often after they have the baby, they're okay, but we'd like to see them still, because if there's still some hypermobility, we need to bring that back to a good place, restore to factory settings, so that they don't have more chronic pain, because then the pelvic floor starts to hold too tight because the muscles here are not doing the right thing. So then we end up with a pelvic floor dysfunction 3-4 years later. So it's complex. Strapping helps, SIJ belt helps, supportive tights will help because it's just trying to keep the things together during the pregnancy.
Superb. Thank you for that. I want us to do Q&A, then we open another voice. So there's a question around, colleague, we will continue until exactly 1:15. If we get to that time and we haven't gone through all the questions, we will do a Q&A and see if we can reply written, but
Sure.
we are planning to have follow-up sessions as well. So I hope that we will have enough time. Yeah, okay. So there's a question about an 8-year-old who was involved in a vehicle accident 6 months ago.
Right.
Now
Right.
she has bowel control issues, mistakenly poops on themselves. The question is, could this be a pelvic floor problem or psychological? Because in terms of the clinical assessment, no injuries were identified.
And no
the-
spinal cord
No pain.
injury. And no spinal cord injury.
Well, I suspect no obvious injuries.
Okay.
Yeah, no obvious.
So,
yeah.
So she had an accident, and what was fractured? Sorry, I missed that.
Nothing was fractured. No.
Nothing was fractured. Okay.
No injuries. Yeah.
Okay.
No
So trauma is huge. Remember, S234 keeps your pee and poo off the floor. But to pee and poo, we also need to be in a parasympathetic state and not a sympathetic state. If we're in sympathetic, we're going to be squeezing the pelvic floor because we're running away from the lion. We're not going to pee and poo. But in order to pee and poo, we need to be in parasympathetic to let go of the pelvic floor. Now, if it's an 8-year-old, probably this whole event was quite traumatic. Did you say 8 years old? Am I right? It's a kid?
8 years old, yes.
So traumatic, they don't always have the verbal words. They don't always understand what their emotions are. So they can't say, listen, I'm traumatized, I'm stressed, I'm so scared of going into a car, I'm so scared of what happened to me. It will manifest physically. So they hold, right? And then the poo backs up. Kids are master holders. So the poo backs up. If the poo stays in the rectum for too long, more water is absorbed. So the poo backs up, and then the new poo that's coming along comes down the descending colon, doesn't have enough time to become solid, and goes around and comes out as an accident or a liquid poo. So more than likely, this kid is constipated because of the trauma, because of maybe being in hospital, because of the medication, and the trauma is now causing a bit of an impaction, and then you're getting the overflow diarrhea, which is causing the accidents. So we need to get them cleared before we can even look at pelvic floor.
Superb. All right. I lost 2 hands. Okay, let's take Jackie Mashabela. You may unmute Jackie Mashabela.
Yeah, I don't know if you can hear me.
Yes, I can.
Thank you.
Oh, okay. I'm a physiotherapist. I'm currently doing my ComServ.
Awesome.
So I've currently had patients that had difficulty with pelvic floor muscles, especially because I work at a clinic. I work in rehabilitation. So most of my patients are old and are diabetic. So it's that case of where you have patients suffering with nerve conduction and muscle control due to entrapment at a mechanical interface. Yeah. So I heard you speaking about Kegel exercises and all of that for muscle contraction and improvement of muscle strength and pelvic floor muscle strength and all of that, controlling breathing. But what do we do in a case where we have a nerve conduction problem, especially with patients that are, especially, let's say, diabetic? Most patients like that present with a nerve conduction problem and all of that, and that will affect the muscle control and all of that. Is there a way that physios can help release the muscle from trapping the nerve and also stimulating the nerve, besides using strengthening exercises? Is there like modalities that we can use to improve the nerve conduction?
Okay, so as far as I understand, elderly diabetics will more have peripheral neuropathy more than they have it distally. So if they are having a lack of sensation already in the pelvic floor area, which is quite proximal, I would be concerned that their diabetes is quite far along. I've never experienced that. Normally it's the feet that are the issue and not so much around the pelvis area. So if it is, if the nerves in the pelvis are okay, then awareness, trying to get sensory control, and using the glutes, tummy, ab and adductors is a good way to try and get pelvic floor to work together with the whole complex. If there's a lack of sensation because there's peripheral neuropathy within the pelvis, then we're on a different ball game altogether. We're not going to get those nerves back. If they're trapped in a muscle, we need to release it internally, which if they're elderly, I'm not sure how much of that you're going to get right. But then perhaps we need to look at alternate ways of managing bladder and bowel, which might be intermittent catheterization if they're not emptying fully, so that we're preventing urinary retention, which is going to cause more issues if they get bladder infections. So it's quite a loaded question. I don't know that I've answered it all for you, but it's quite complex. So I think we'd have to look at each individual case and see what are all the factors that are affecting that specific case.
Superb. Someone is asking, I'm sure it's a quick one, this one. Does sitting on a bathtub, can it affect your pelvic muscles in some way? Sitting, I think maybe they're talking about bathtub. Sitting on a bathtub, I don't know if there's a myth around that or something.
No, not that I'm aware of. Not that I'm aware of. So go ahead, have a great bath, relax your pelvic floor, explore it while you're in the bath. Why not?
All right. Someone says a 42-year-old previous Caesar ×2 complains of an urge to urinate during intercourse. And before you answer, someone asked about the squatting and whether squatting during sexual intercourse is a sign of pelvic floor muscle weakness. Squatting, you know, when people
squirting. Oh, right.
Yeah,
squirting. Okay. So yes, generally it's the scar that is irritating, the Caesar scar. Remember, superficially we're seeing just the scar superficially, but you've cut through so many layers. Each of those layers need to heal. So the scar can be quite deep. That scar is quite close to where the bladder is and can be irritating the bladder through the fascial system. So definitely pressure on the scar or contraction around the scar can definitely cause the urge to pee during intercourse. Also remember, sexual pleasure, peeing and pooing are all on the same nerve root. Okay, parasympathetic autonomic system. So you could be experiencing pleasure and the urge to pee at the same time. That can happen, and it's often related to the scar. Squirting. Okay, so our clitoris is an amazing thing. That's another hour lecture. Our clitoris is massive, and it's also like men ejaculate. The clitoris also ejaculates, except most of us are not even aware of it. And so perhaps that squirting is that you've got a fantastic clitoris and that it is giving you a bit of an ejaculation, I hope.
All right. So let's take these two last hands and then you'll reply to both, I think, and these are the last two hands.
Okay.
Then we'll have some important closing questions. Yoliswa, you may go first, and then Mary, you'll be the last.
Hi, Ms. Tasvi and
Hi.
Mr. Lesego. How are you?
Good, and you?
I'm good. So we had a patient come in in the beginning of the week. So we had a 29-year-old female who has had 3 kids delivered via NVD and is currently presenting with a uterine prolapse, a grade 1.
Okay.
And has had a prior prolapse like on her 3rd pregnancy. So we just wanted to ask, how would you go about rehabilitating this patient? Because it's also been affecting her emotionally as well.
Yes. Prolapse is huge because you think your whole insides are falling out. So the first thing we need to do is reframe how the words we're using around prolapse. You are not failing. You are not broken. You are womanly, and now we need to just manage this a little bit better. So the words we use are really important. And then also, if it's grade 1, that's awesome. It means that it's not that hectic. It hasn't come out yet, but we don't want it to come out. So we need to know what are the risk factors, what are the things that she's doing that are precipitating the prolapse, and it's usually teaching them how to manage pressure. So is she ever going to not lift her kids? No. So we can't tell her that she can't lift, because if she lifts something heavy, something's going to come out, she'll never lift her kids. She'll live a life in fear. So we need to learn, we need to teach her correct breathing and ways of managing the pressure with strengthening around the abdomen, around the hips, around the glutes, around the pelvic floor, so that we've got the stable but mobile core that anticipates and that manages the pressure as she needs to do her daily things, so that she knows that if some days she's going to have a bad day and she might be more symptomatic, what does she need to do to relieve the pressure? Some days she's going to have good days and she's not going to be symptomatic at all, because everything is working the way it should. But it's looking at her holistically from an emotional point of view as well as a physical point of view, and rehabbing simple things: breathing, core, hips, glutes, adductors, obturator, internus, and pelvic floor at the same time. So you don't have to be doing internal work. You can really look at the external stuff and get that to be working properly. Most women switch off their glutes in pregnancy and never get their glutes back. So even if you're just getting glutes back in action, that will make a huge difference for her.
Nice.
All right, thank you so much.
Thank you. I
Sure.
also learned something there. Mary Augusta, are you able to unmute? Yes, thanks.
Yes, thank you so much for the informative talk.
You're welcome.
My question has been answered. Thank you so much.
Oh, awesome.
Yes.
Sure.
All right. Superb. Maybe let's summarize it this way. The other questions, colleagues, we will find a way to respond to you. So I want to start to close, but I have the following. The toilets, modern toilets, are they contributing to the problem?
Yes, 100%.
Going back to the native way of doing
100%. 100%. I grew up on a flat toilet. I was scared as hell to learn how to pee and poo on that toilet. But the minute I could go onto a normal high toilet, I was so excited. But that's also been half my problem in life. So we're not going to all use squatting toilets. That is the reality. And sometimes I think our toilets are getting higher and higher. So we're going more into an extended position. So simple, just get a footstool, go to Western Pack, go to a plastic shop, get a footstool, make sure your knees are higher than your hips, because automatically your sacrum goes out and your pelvic floor lengthens. It's simple biomechanics. If we could squat giving birth, if we could squat for a poo, then we're winning.
Would be better.
So sorry, definitely we're not going to go back to flat toilets, but you can modify your toilet for sure.
Superb. So there was a question that says, do all physiotherapists do pelvic floor management? No. And for your response, then someone said, it's Orient. Orient said, it's a field, I don't know. I don't know where to start. So Orient has an interest and he says he doesn't know where to start, but someone is asking, can we refer everywhere, or how does it work? Yeah.
Okay, so it definitely is a postgraduate specialty field. I know WITS because I'm associated with WITS. They do like one lecture in fourth year, which is Introduction to Pelvic Health. So it is not something that is taught at an undergrad level at all, especially when it comes to internal work. Postgraduate, you can do it on various levels. You can just do introductions where you're learning about pelvic health generally, or you can take it further where you then also learn how to do internals, PVs, PRs, treat men, treat children, that stuff. So definitely postgrad. In our country, we don't have a lot. It's growing. It really is growing. So if you go to SASP or you find our Facebook group, you will be able to find a list of therapists that are trained.
Superb. So there was a comment from Tangisen. She says, I see what I was doing wrong all along. I'm reading this for your own feedback, because the aim is to transform one health worker at a time.
Exactly.
Based on just her feedback alone, I think it's positive. I also want to chat. We are about to close. I know the family has been patient there as well.
Yes.
There's a lot of positive feedback from colleagues that they really appreciate this talk. What I want you to do is to share your closing remarks. And then some people are asking, how can they contact you? I mean, you decide if you want to share some email or you prefer that, whichever way, then we take it from. Yeah. Thanks.
So you can contact me if you're going to share the slides. My contact details are at the end of the slideshow. So if you share my slides, it's there. And also my closing comments. I'm glad you found it informative, because if now you know you have a pelvic floor, now you know how to activate your own pelvic floor. And if you can connect to your own, or if you can connect to your own pelvic floor, then you are already 50% there to helping patients connect to their pelvic floor. And if, like I said, if we can connect, if we can change one pelvis at a time, we're doing a lot of good in this world.